Okay, anyway, today we're going to talk about liver function tests. So mag-start na tayo when there are still a lot who are not yet here. Okay. So in the context of, sorry. So in the context of, we will discuss liver function test in the context of its use on clinical diagnosis or in the management of your patient. So as we go along in the lecture, uh, a lot of tests, a lot of disease entities that will be mentioned, but will not go through each of the detail, but rather more on how the liver function tests are being used on their management. Okay. So before we even have to discuss the liver function test, we have to discuss first the functions of the liver. Okay. So the metabolic functions of the liver would include synthetic function because it is the organ that synthesizes plasma proteins or cholesterol, triglycerides, and your lipoproteins. Each of those are being discussed in different topics in clinical diagnosis. So the plasma proteins was discussed in CDA, I think cholesterol and triglycerides, uh, including lipoproteins, were also discussed in CDA. The other function of the liver is in detoxification and excretion. And detoxification, it's involved in the removal of drugs and drug metabolites. It's also involved in the removal of ammonia to urea. So I think I don't know if this was the class who had the CPC on where consideration as hepatic encephalopathy, and one of the tests that you have to do is an ammonia test. Okay, next is in the storage function of the liver. It stores vitamin A, D, E, K, and B12, and diseases that would be related to those vitamins, such as deficiency of or hypervitaminosis, will be reflected in the liver function tests. Okay. And lastly, the production of bile salts that helps in the digestion. So how is the liver become dysfunctional? When there is direct cellular injury, when there is blockage in the bile flow, and where there is impaired blood flow to the liver. Okay. So first, on the direct cellular injury, our example here is hepatitis C infection or hepatitis C hepatitis. So here you see this hepatocyte. This hepatocyte is swollen, and you know that's the first of the changes that you will see in cell injury. So this is swollen, but this one here is already necrotic. Okay, it has already died. And in necrosis, you know that the cell membranes fracture. The cell membranes are disrupted. When the cell membranes are disrupted, the intracellular contents will leak out to the interstitial space and eventually rejoining the circulation. Once in the circulation, they can be measured. So enzymes which are present in the hepatocyte can reach the blood circulation and can be elevated in cases where there is direct cellular injury. We'll talk about those enzymes in a little while. Another mechanism of liver dysfunction is in the blockage of the bile flow. One of the metabolic function of the liver is in the excretion or in the detoxification of your or the catabolism of your heme, which is part of when there is hemolysis of the red cell, hemoglobin is freed and hemoglobin becomes heme and globin, and heme will be further catabolized into bilirubin, and bilirubin will go to will be excreted in the bile. And when there is obstruction in the bile flow, such as in this slide where there is biliary atresia, there will be damming back of the bile, and you will see these bile lakes. These bile lakes. Another is the impaired blood flow, or this is also known as ischemia or ischemic injury to the hepatocytes. The liver is a very complex structure. It's composed of hepatic lobule, and this is one hepatic lobule here, composed of cords of hepatocytes. So this is one lobule, cords of hepatocytes, and this is the hepatic triad. The blood flow and oxygenation of the liver is also unique. So the oxygenated blood flows from the hepatic artery through the sinusoids here, and then reaching the central vein here, going back to the circulation to be again oxygenated. This case is congestive heart failure. In congestive heart failure, there is CPC of the liver, or chronic passive congestion of the liver. And you've seen this already. I think in hemodynamics, you've seen this in hemodynamics, but also in your hepatobiliary, you get to see this in your pattern B. So what happens is from the hepatic artery, oxygenated blood flows towards this direction. And since there is congestion, because there is congestive heart failure, the blood cannot flow readily going here. Okay. So only those that are in this part will be oxygenated, or hepatocytes in this part will get the share of the oxygen. And those that are in here, I think this is zone 3, will not have the oxygen. And you know what happens when there is less oxygen? The cell goes into initially reversible cell injury, becoming irreversible, and will go into necrosis. That's why here you see this necrotic area here, that one. So it becomes patchy and becomes an appearance. So that is one of another. This is the second mechanism of liver dysfunction. Because when cells die by ischemia, they also release the cellular contents. Okay. This is just an illustration of how the liver injury and how the liver will cope with that injury. So in liver injuries, in any cell injury, the cell can die if the injury persists, the injury progresses. So liver cell, when a liver cell dies, it can be, the liver is a liver tissues have quiescent cells, meaning they are not readily replaceable, that they can be replaced by stem cell proliferation. Okay, and that stem cell proliferation, if sufficient, will be able to fill the gap of those cells that died, and that will lead to recovery of the function. But if it's inadequate, the replacement is inadequate, it can go into liver failure. That is in terms of function. Okay, but when you talk about the architecture or the structure of the liver, when there is proliferation, the structure is preserved. But when there is too much of the cells are dying, too many of the cells are dying, in chronic inflammation, we've learned that if there is tissue loss, there will be fibroplasia or replacement by fibrosis or by collagen deposition. And that fibrosis in the liver can alter its structure, resulting into cirrhosis. Okay, you've seen already cirrhosis of the liver in repair, inflammation and repair. So that was in patho. When you go to pathobiliary, you will see that again. So in cirrhosis, there will be an impaired function of the liver. But the beauty about the liver, it has a very large reserve. It can still function. You don't actually die of liver cirrhosis instantaneously, or you don't die of just of liver cirrhosis. But by the complications it brings. Okay, so these are some of the diseases of liver that will be that will manifest as liver dysfunction. First, there are hepatocellular diseases, various hepatocellular diseases, cholestasis or that can be caused by cholestolithiasis or cholelithiasis that obstructs the bile flow. Cirrhosis can be cirrhosis of various causes, alcoholic liver cirrhosis, and the rest. Okay. Hepatitis also have viral hepatitis and even drug toxicity can cause hepatitis. Jaundice as a manifestation of liver dysfunction, hepatocellular carcinoma and other malignancies of the liver, and steatosis. And there is a genetic disorder that will also affect the liver. This is hemochromatosis, which is about iron storage genetic disorder. So we do liver function tests, or we order liver function tests to assess the liver, to assess its function. But we also do liver tests to screen for diseases, okay, to screen for liver disease. So one of the purpose of doing liver test is to screen for this liver disease. Another is to aid in the distinguishing the general types of disorder, or aid in the diagnosis of liver disease. Another is in the assessment of severity and in predicting the outcome of a disease, or what we call as prognostication of a disease. And we also use a liver function test in the monitoring of our treatment. So liver function tests are classified broadly into tests that will detect hepatic injury. Those tests can help you in classifying the liver injury. Is it mild? Is it severe? Is it acute or chronic? And even sometimes the nature of the liver injury. The second classification is that tests that will assess the hepatic function. Okay. And these are further grouped into markers of liver dysfunction, such as bilirubin, the bile salts and urobilinogen in the urine, total protein. This is as mentioned earlier, the synthesis of proteins are in the liver, and the prothrombin time. The second group is that are those tests that will be used as a marker for hepatocellular injury. These are enzymes. These are the liver enzymes that are present in the hepatocytes. When hepatocytes go into necrosis, when they die, these enzymes are released into the interstitial space and will be detectable or measurable in the peripheral blood circulation. So you can do these blood tests. And another is those tests that are used for as a marker rather of cholestasis. And this one of these is the alkaline phosphatase, and the second is gamma glutamyl transferase. I'm grouping these tests so that it will be easier for you to remember. Okay, liver function tests have limitations, and one of that is when they are normal, they not always indicate the absence of liver disease. Okay, because liver has a very large reserve capacities. For instance, albumin becomes abnormal only when you lose 80% of the liver capacity. That's long enough. No. The other is asymptomatic people may have abnormal liver function tests. So liver function test may not be as specific about the presence or the absence of the disease. Okay. So the lesson here is liver function. You should take liver function test with I mean, you should not just see a liver function test as it is. Now you have to correlate it with your PE, with your clinical examination, with your history, and even other tests, other diagnostic modalities as well, ultrasound, X-ray. So these are the tests, and the tests on the left and on the right are the clinical implication. Most of the liver function tests are done in the clinical chemistry section, but not all. Say for instance, liver like urobilinogen, urine urobilinogen are done in the clinical microscopy. Prothrombin time. Prothrombin time, when you are this is used to measure the or to assess the coagulation pathway, but this is also used to measure or to assess the synthetic capacity of the liver. So it has different usage, but this test is being done in hematology. So the two enzymes there, alanine and aspartate aminotransferases, as mentioned earlier, are used to assess hepatocellular damage. Your bilirubin and alkaline phosphatase would assess obstructive diseases in the liver, such as cholestasis and biliary obstruction. But it can also be used to assess impaired conjugation of bilirubin. Okay, for bilirubin. Alkaline phosphatase, on the other hand, later you will know why they are being used to assess infiltrative disease to the liver. Ano yung una doon? Masses or even TB of the liver can be infiltrative. So hepatocellular carcinoma, liver adenoma can be can cause changes in the alkaline phosphatase as well. Prothrombin time and albumin, these two substances are synthesized in the liver. That's why they are used to assess the synthetic function. Your bile acids and your gamma glutamyl transferase are used for cholestasis and biliary obstruction. So unlike bilirubin and alkaline phosphatase, these two are only used for cholestasis and biliary obstruction. Bilirubin has an added use such as in impaired conjugation, while alkaline phosphatase for infiltrative disease. Bakit nawala na ang mga may camera sa inyo? Are you studying for your plating? Okay, we'll go to each of the liver function tests. We'll start with bilirubin. And bilirubin, we know, is a byproduct of red blood cell breakdown from the breakdown of heme into biliverdin and biliverdin to bilirubin. Okay. It is a yellowish pigment. That's why when it is elevated, it will cause hyperbilirubinemia and it will be seen in the skin as jaundice. And if it's too high, like the unconjugated bilirubin, it can cause kernicterus in the brain. Okay, hyperbilirubinemia is observed in gallstones, in acute and chronic hepatitis. So obstructive, it can be seen in obstructive liver disease, such as in gallstone, and also in hepatitis, which is a different pathophysiology, which is hepatocellular injury. Why? Because bilirubin conjugation happens in the hepatocytes as well. It is water insoluble. Bilirubin, the indirect bilirubin, is water insoluble, but that's why it cannot go into the liver. It can go into the liver by binding to albumin and then conjugation with by removing the glucuronic acid attached to it. Okay. So this is bilirubin is taken up by the liver and conjugated in the hepatocytes and excreted in the bile. So in the bile inside the uh, gallbladder going into the ampulla vater or ampulla vater. That's why this is a good indicator if you are suspecting obstruction. So if the obstruction is below the ampulla, the vomitus will be greenish. But if it's above it, then you will not see the green coloration of bile because it's above the point of excretion to the intestine. How is bilirubin formed? It is from heme, and heme originally from the hemoglobin breakdown of hemoglobin, di ba? So heme oxygenase will act on heme, it will now become biliverdin, and biliverdin is acted upon by biliverdin reductase to become bilirubin. And bilirubin is transported in the circulation by H bonding or binding to albumin. Okay, and this is the illustration of how all that happens. Sana pa yung marker ka? Okay. This is the circulation. So this represents the circulation where the hemolysis can happen, where the heme is broken down. So heme is taken up by the macrophage in the reticuloendothelial system. Also, when old red blood cells are sequestered in the spleen, it's taken up by macrophage, and the heme is broken down. I mean, hemoglobin is broken down into heme and hemoglobin. So heme will be, as I've said, will become bilirubin eventually. So bilirubin initially is, or the indirect bilirubin is unconjugated, and this is water insoluble. So it can enter the hepatocytes or the liver when it's bound to albumin. Once in the hepatocyte, okay, it is conjugated with glucuronic acid, and then the conjugated bilirubin. When you say conjugated to glucuronic acid, that bilirubin is already conjugated. When we call it conjugated bilirubin, it is already conjugated with glucuronic acid through the action of those enzymes mentioned earlier. Okay, your conjugated bilirubin then will be, or will join we will go to the gallbladder through the biliary tract as a part of the bile. Once in the intestine, it will be acted upon by the bacteria. Okay, and glucuronic acid is removed, resulting into bilirubin becoming urobilinogen. Please take note of the urobilinogen. Urobilinogen can be reabsorbed from the intestine, go to the circulation, and may go back again to the liver and getting excreted in the intestine, okay, or in the feces. Okay, in the feces, this urobilinogen is oxidized again by other intestinal bacteria to become stercobilin, giving color to the stool. That's why if the stool is like color, I mean parang white lang siya, pale na ano, this can mean obstruction in the bile flow, probably because there's no bilirubin reaching the intestine, becoming stercobilin or urobilinogen and stercobilin. Some of the urobilinogen will go to the kidneys, and it is converted there to urobilin, giving the yellowish coloration of the urine, the characteristic color straw to yellow. Okay. This is another circulation, pareho lang naman ito. How will be, okay, by the way, liver function test, for all liver function tests, it's non-fasting. You no need to fast for uh, testing for bilirubin. But bilirubin, by the way, is sensitive to light. So the old way of measuring bilirubin, kailangan naka-ano siya sa dark. Ano. But now we measure bilirubin with analyzers already. So we don't do that anymore. Okay. And bilirubin is, naisip ko lang, no? But since bilirubin is sensitive to light, that's why yung mga bata na jaundice na pinanganak, they're exposed to the light, diba? Now, there are values here, the normal concentration, those that will result into jaundice. You don't need to memorize that. What I'm just trying to say here is that once levels increases, you can have jaundice, or you start to see jaundice. Again, you don't need to remember that bilirubin is tested through the diazotization reaction. I just mentioned this because the diazotization reaction will involve the reaction of the bilirubin to the diazo reagent. Bilirubin, I mean conjugated bilirubin, or your direct bilirubin will react faster with the diazo reagent. That's why it's called the direct bilirubin. Siya yung unang na-measure, tapos mina-minus na lang yan dati. Okay, and but unconjugated bilirubin reacts very slowly. That's why it's called indirect bilirubin. And again, these are different levels of bilirubin that you need not memorize. Okay, so bilirubin can be used to, or can help you determine if the disease or the one causing the hyperbilirubinemia is prehepatic, hepatic, or post-hepatic. Okay, so if there is hemolysis, there is too much of the heme being dealt with the liver, then it cannot be conjugated. So you will have a higher indirect or non-conjugated bilirubin. Whereas those in hepatic disease, both conjugated and unconjugated may be increased. And then after the liver, if the obstruction is after the liver, the increase in bilirubin is mostly on the conjugated only. So unconjugated, prehepatic, hepatic naman, both conjugated and conjugated, post-hepatic, just mostly the conjugated bilirubin. Okay, so so the jaundice will be classified into prehepatic, hepatic, and post-hepatic, and the causes are on the right. So I'm just giving you tables, so it will be easier for you to memorize them because I will be asking this. Okay, so when there is hemolysis, there is destruction of of red blood cells. And what are those diseases like in hemoglobinopathies, when there is hemolytic transfusion reaction, when there is thalassemia, or drugs that cause hemolysis, this will be prehepatic in picture, and conjugated bilirubin will be increased. There's also Gilbert's and Crigler-Najjar, and you study this in your biochemistry, wherein there is a problem in conjugation. Enzymes of conjugation cannot perform its function or are not present, then your unconjugated bilirubin increases. That's called your prehepatic jaundice. Your hepatic jaundice or hepatocellular, just like when there is damage to the cells, then you can have hepatic jaundice. So viral hepatitis, toxic hepatitis, those that can kill the hepatocytes, and even intrahepatic cholestasis. Yeah, there will be cases where there is obstruction within the liver, even in biliary atresia. Okay. Post-hepatic are caused by stones and tumors of the bile duct, and even in the pancreas. those that can impede the flow to the intestine, or like the pancreatic carcinoma of the pancreatic head. We go to urobilinogen and the bile acid. So most of the urobilinogen is metabolized in the large intestine, but some of it are actually excreted in the urine. Okay. Normally, your bile salts, on the other hand, are not present in the urine. Okay, and obstruction in the biliary passages will cause leakage of the bile salts into the circulation. So once in the circulation, it will be excreted in the urine and detected in the urine. Okay, so when there is obstruction, you will see bile salts in the urine. We go to albumin, the most abundant protein. And in fact, you have special lecture on plasma proteins alone. So we'll just go through albumin very fast. Okay, the most abundant and synthesized in the liver, hence is a marker of synthetic impairment, synthetic liver function. Okay, so forget about normal serum level. Okay, and this is the level of albumin is proportional to the functional to the number of functional liver cells, no, or the liver cell mass, and it has a long half-life, so it's just enough for you to remember that it's just a long life. That's why drugs that are bound to albumin have a long life also. Its level will decrease in chronic liver disease and in illness. In acute inflammation, there is the release of cytokines. In your pathway, you learn this in inflammation. These cytokines will increase the catabolism or the metabolism of albumin. Hence, this is decreased. So in inflammation, in acute illness, there can be a decrease in albumin. Okay. But albumin can also be decreased in nephrotic syndrome, where you lose the urine in the protein. Next is the globulin. Globulin is more like used in the albumin globulin ratio. And globulin are mostly alpha and beta globulins that are synthesized in the liver. And the major fraction of immunoglobulins are, the major fraction of globulins is represented by the immunoglobulins, which are the antibodies. So in infection, in inflammation, where there is abundance of, or there is an increase in the synthesis of antibodies, there is an increase in globulin, and that will affect the albumin to globulin ratio. High serum gamma globulins will be seen in chronic hepatitis and cirrhosis because of the inflammatory process going on. Okay, and particularly IgG for autoimmune hepatitis and IgA in alcoholic liver disease. So you've known already in your pathway the importance of albumin to globulin ratio. When globulin increases, the ratio decreases in compensation. Now we go to prothrombin. So prothrombin time, as Heb said, is a measure of the coagulation pathway, but in the context of liver function, it is used to measure the synthetic capability of the liver, the synthetic capability to synthesize clotting factors represented by your prothrombin. Okay? And may half-life na yan. So when there is deficiency of prothrombin, the pro time is prolonged. And this is only seen when 80% of its reserve, or the liver reserve, is already depleted. Okay. But in vitamin K deficiency, prothrombin time is also prolonged. So in order for you to know if the ProTime, the prolongation of ProTime is secondary to a liver disease or a vitamin K deficiency. I mean, you need to know which one will. So how is that? How is that done? You have to give vitamin K, but not orally. Okay, you give vitamin K subcutaneously. Later sa next slide ko yun. Sorry. Ayan. So you give vitamin K 10 milligrams subcutaneous. Hindi ko na itatanong yung dosage na yan. And then you have to do the prothrombin time. If the prothrombin time is corrected, the pro time and the prolongation of the pro time is not about the low levels of prothrombin, or it's not because the liver is not producing prothrombin, but it is because there's vitamin K deficiency. Not given orally, ha? I mean, oral vitamin K does not correct ProTime. Next are the enzymes. So your aspartate aminotransferase, or AST. This is marker of hepatocellular injury because they're found inside the hepatocytes. When the hepatocytes burst or go into necrosis, it will be released in the circulation. And what are those conditions? In chronic hepatitis, in cirrhosis, and in liver cancer, where you see high levels of aspartate aminotransferase. Next is your alanine aminotransferase. This is more liver specific, okay, compared to your AST. And this is increased in acute hepatitis. The reason I presented there the normal levels is because high serum levels as much as 300 to 1000 UL can point into acute hepatitis. Moderate elevation will be seen in alcoholic hepatitis at a level of 100 to 300. But minor elevation can be seen in hepatitis C and in non-alcoholic steatohepatitis, or NASH. Well, this is around about 50 to 100. But normal patients, even me, I have high ALT sometimes. Okay. Asan na? Mali yung cue ko. Mauna muna tayo. That ALT can be deranged already before the clinical signs appear. So kailangan mo talaga i-correlate siya. A normal value does not always indicate the absence of a liver disease. However, but an increased ALT does not necessarily mean also that there is liver disease, such as in case of obese patients. So if you have high levels of cholesterol, you can have mild elevation of your ALTs. Next is your ALP, or your alkaline phosphatase. Alkaline phosphatase is a non-specific marker of liver disease. It is non-specific, but it has its use in the obstructive disease of the liver. So this is also produced in the bone osteoblast and also in the placenta. Okay, so they are present on the hepatocyte membrane. Nasaan yung hepatocyte na yun? Doon near the bile canaliculi. So alkaline phosphatase is elevated moderately in infective hepatitis, in alcoholic hepatitis, and in hepatocellular carcinoma. They are found in hepatocytes that line the bile canaliculi, not on the bile canaliculi, but on the hepatocytes near it. Okay, when there is obstruction, they can be stretched. I mean, those hepatocytes near the bile canaliculi, when they are stretched, they will release alkaline phosphatase, and alkaline phosphatase will be elevated. But as I've said, this enzyme can be found in the bone and the placenta. So you need another test such as GGT, which is found in the bile canaliculi, but can also be increased in cases of I mean, certain drugs and alcohol. So, okay, class, you have to like play there's an interplay of these enzymes. So you just cannot use one and then make your conclusion. Okay, GGT can be raised with some drugs, no, and alcohol. So alkaline phosphatase, ayan. Alkaline phosphatase can be very high or are very high in bone diseases, but high levels of it can be an indication of extrahepatic obstruction and intrahepatic cholestasis. Your gamma glutamate transferase, this is used in the synthesis of glutathione, but it is elevated in biliary obstruction because they are found in the bile canaliculi. They are moderately GGT is moderately elevated in infective hepatitis and your prostatic cancer. As I mentioned earlier, GGT is increased in alcoholics. That's why it is a good and sensitive way of detecting alcohol abuse. Okay, now these are the patterns of the different tests derangement. So when it is hepatocellular, when it's the transaminases that are primarily increased, it's probably hepatocellular. And what are those diseases? Your viral hepatitis, viral hepatitis, your drugs and alcohol, autoimmune hepatitis, NASH, and your hemochromatosis. If it is obstructive, the ones increased are your alkaphos and bilirubin. But your transaminases may also increase, but not as much compared to the increase of transaminases in hepatocellular disease. And what are the conditions? Obstructive conditions such as when there are gallstones, primary biliary cirrhosis, sclerosing cholangitis, and your pancreatic carcinoma that obstructs the biliary flow. Okay. In alcoholic liver disease, we use the Deritis ratio. You can read it, Deritis ratio. I think the spelling is DERITIS. It's a ratio of AST and ALT. And in alcoholic liver disease, AST is more elevated at a ratio of 2:1 to 3:1. The AST can be as high as 300 or so. And why is that? What is the reason why AST is elevated in alcoholic liver disease? Because alcohol has increases the synthesis of AST. And on the other side, ALT is inhibited by vitamin B6 deficiency. So in alcoholic liver disease, there is usually vitamin B6 deficiency. That's why ALT becomes lower even more, and your AST becoming higher even more. So that's why the ratio there is like that. So these are the levels of your AST in the various diseases. Now, your viral hepatitis, we will not talk about that, but I'm just presenting it here because your viral hepatitis, your hepatitis also have its own markers. It can be IgM, it is an acute infection. If it's already recovered, you'll have IgG, and these are those. We'll not be asking anything from this. So what are our generalizations? Your liver function tests can detect liver injury and function, but you have to be judicious about its use and its interpretation, and because it has some limitations. Okay, with that, I end this lecture. Do you have questions? I already gave you, please check the chat box. I gave you the handouts. Okay, so if there are no more questions, I will end this session.